Assalamu alaikum. I'm Dr. Ramisha Zahid Shah, consultant histopathologist, and today we are going to discuss lymphomas. So today we will be discussing very important lymphomas, that is the Burkitt's lymphoma and lymphoblastic lymphoma. The very reason they are important is because they are seen in children and young adolescents. They are very aggressive, but the good thing is that they are treatable. So let's talk about Burkitt's lymphoma. Burkitt's lymphoma is, like I said, highly aggressive but potentially curable. It is an EBV-associated B-cell lymphoma. It has three subtypes: endemic, which is 100% EBV associated, and it is seen in African population. It can affect jaws, it can form orbital lesions, it can affect the GI tract, ovaries, kidneys, breast. Then comes the sporadic, which usually affects the abdominal cavity, and then is the HIV infected, immune deficiency associated, seen in HIV infected individuals. While the endemic subtype is 100% associated with EBV infection, the sporadic and immune deficiency associated Burkitt's lymphoma show 20 to 40% association with EBV. So we can classify them as EBV associated and non-EBV associated as well, but it is just a proposed classification and not accepted by WHO yet. So as for now, we have three subtypes: endemic, sporadic, and immune deficiency associated. So if we talk about the morphology, it has a very characteristic morphology. The cells are squared off. They are medium sized and they have squared edges. They fit in and have small windows in between. There are scattered macrophages that give it a starry sky appearance. The borders are squared off. There are windows and gaps between the cells. The nuclei are round and chromatin is clumped, and we can see several nucleoli in it. The characteristic feature is that the proliferation index is 100%. So if we apply a Ki-67 stain, we can see almost cell-to-cell staining in it. Here's a picture that we can see the Burkitt's lymphoma. We can see the starry sky appearance made by the tingible body macrophages. The cells are squared off. We can see multiple nuclei in each cell, in each nucleus, and there are gaps and windows between the cells. So if we go for the IHC, it is a CD20 positive, CD10 positive, BCL6 positive lymphoma. So it originates from the germinal center. Moreover, it is EBER positive and EBNA1 positive, like I mentioned that it is EBV-associated lymphoma. But it is BCL2 negative, it is TDT negative, LMP1 and EBNA2 negative. Chi-67 is 100%. So let me explain these EBV markers a bit over here. EBNA1, it shows nuclear positivity, and it is positive in all EBV-associated cancers. It is a nuclear antigen, and it is positive in all EBV-associated cancers. As far as EBER is concerned, EBER is an RNA. It shows nuclear positivity, and it is a microRNA, a non-coding one. Its function is to promote cell survival and induce interleukin 10, and it is positive in Burkitt's lymphoma. LMP1, not positive in Burkitt lymphoma, but seen in other EBV-associated tumors. It upregulates BCL2 and prevents apoptosis. It shows membranous positivity and cytoplasmic positivity. However, it is negative in Burkitt lymphoma. So these are a few EBV-associated IHC markers that we can use. Just to note that EBER is positive in Burkitt's lymphoma while LMP1 is negative. Like we discussed previously, that Burkitt lymphoma may or may not be associated with EBV. So, if we just talk about a brief IHC profile, I won't be wrong if I say that it's a CD20 positive, CD10 positive tumor with BCL2 negativity and 100% Chi67. This is the shortest IHC profile that we can see in a Burkitt lymphoma. Fish is very important for diagnosis of Burkitt lymphoma. It is considered mandatory now to support the diagnosis of Burkitt lymphoma, and we can see MYC on fish, which is diagnostic. It can be the translocations can be T8, 14, 822, or 28. Absence of BCL6 and BCL2 is important. So if you recall that when we were discussing large B-cell lymphomas, we also applied fish in case of MYC and BCL2 positivity, and that was to rule out high-grade large B-cell lymphoma. That applies here too. As soon as we see a case of Burkitt lymphoma, it is a medium-sized cell. It has medium-sized cells. We go for fish studies, and we can get a couple of possibilities when we apply fish with this kind of morphology. So either it is MYC only positive, which means it is diagnostic for Burkitt lymphoma. Otherwise, we can also see same morphology with MYC negativity on fish and 11q positive aberration. So, Burkitt lymphoma, with it was previously called Burkitt-like lymphoma with 11q aberrations, but now it is called high-grade B-cell lymphoma with 11q aberration. Then we can have MYC negative and 11q negative, and which makes it a high-grade B-cell lymphoma, not otherwise specified. And last but not the least, we can have MYC positivity, BCL2 and BCL6 positivity. And if you recall, we call it a high-grade B-cell lymphoma with MYC BCL2 rearrangements, and it can be seen as a double expressor on morphology with IHC. So these are the four possibilities of fish when we see this kind of morphology. So it is mandatory that we perform fish studies to confirm Burkitt lymphoma. A few points to remember: it is highly aggressive, but the good point is that it is potentially curable. It has excellent prognosis, and all of these types can affect CNS, the endemic, sporadic, and the immune deficiency types. So the best treatment is to accompany the CNS prophylaxis. The extent of disease is the most important prognostic factors, and there are other few factors that indicate a poor prognosis, like CNS involvement, very commonly seen in Burkitt lymphoma if it is not treated, or if CNS prophylaxis is not given. Then is the bone marrow involvement, early relapse within 6 months of treatment, and increased LDH levels. So CNS prophylaxis is very important in treatment of Burkitt lymphoma. It is curable and aggressive tumor. Now let's talk about lymphoblastic lymphoma, another lymphoma that is seen in children and young adolescents. The important thing about lymphoblastic lymphoma here is I'm discussing it here because it is an important differential of Burkitt lymphoma. Please note that Burkitt lymphoma is a B-cell neoplasm, while a lymphoblastic lymphoma can be a B-cell lymphoma or a T-cell lymphoma, but it is important to discuss here as it is a childhood lymphoma and often seen as a very important differential of Burkitt lymphoma. Lymphoblastic lymphoma, like I said, it can be B-cell or T-cell. The blast cells can be B or T type, and if it forms a mass lesion, we call it a lymphoma. But if it involves bone marrow or blood, then we label it as leukemia. Morphology consists of small cells. There is a diffuse population of small cells in the form of sheets. The chromatin is fine. The nucleoli are not prominent in contrast with Burkitt lymphoma, which has very prominent multiple nucleoli. But in lymphoblastic lymphoma, the nucleoli are indistinct. The mitosis is very frequent, it's common, and here we can see an example of lymphoblastic lymphoma. The cells are small size, the nucleoli are not prominent, and the chromatin is fine. Mitosis is abundant. If we go for IHC, we can have two types of IHCs depending on the lineage of these blast cells. So we can have B lymphoblastic lymphoma or we can have T lymphoblastic lymphoma. But one IHC is common that we will see blast staining TDT. It is positive. It is positive in very primitive blast cells. So TDT will be positive, CD34 will be positive, and then we will see CD19 and PAX5. We can also see CD20, which is an important marker for B cells, but it will be very weak. Since these cells are primitive, CD20 is very weak. T cell markers are negative in this case. However, we can see CD3 positivity on the surface in the reactive population that is scattered in between. For molecular, we have 1221, which has good prognosis, and BCR-ABL2, which has poor prognosis. This is important while deciding the treatment of the patient as well. For T-cell lymphoblastic lymphoma, again, TDT will be positive. It is the marker for blast for primitive cells. CD3 will be positive, but now it will be cytoplasmic as compared to the CD3 positivity on the surface in the B lymphoblastic lymphoma. So CD3 will be positive. It will be cytoplasmic in T lymphoblastic lymphoma. Other T cell markers will be positive like CD5, CD7 can be positive, CD1A is going to be positive. B cell markers will be negative. The molecular shows TCR rearrangement, T cell receptor rearrangements can be seen. Now, here it is an important point that at times we will come across a lymphoma in children that will be TDT positive and CD34 positive. So it is going to show positivity for primitive blast cells, but it will be negative for both B cells and T cell markers. In this case, we must apply at least two to say three markers for each lineage, and in case we apply those markers and we still do not get positivity and we are unable to determine the lineage, then it means that these blasts are very primitive and they have not yet gone to a lineage, and in this case we can refer it to a hematopathologist. The very important differentials, like I said, that Burkitt lymphoma is a very important differential for lymphoblastic lymphoma because of the age of the patient also and a bit resemblance in morphology. But Burkitt lymphoma will always be TDT negative and CD34 negative. As for T-cell lymphoblastic lymphoma, thymoma is a very important differential, and we must note here that T-cell lymphomas, T-cell lymphoblastic lymphomas are seen in diasternum, which is an important site for thymoma as well. So the important point over here is that thymomas have a characteristic morphology as well. They are lobulated and they are positive for keratins. So a simple CK stain is going to help us in differentiating thymoma from T-cell lymphoblastic lymphoma. Moreover, the thymoma is not seen in children commonly. T-cell lymphoblastic lymphoma is a bit more common in children. Here's some recommended material that you can go through, and thank you for listening.